Can you hear me okay? I think this probably isn't working. Thank you so much for joining us. Many of us here are ApoE4 carriers. We're part of a community called the ApoE4.info community. Many of us learned about 5 years ago of our ApoE status through 23andMe. And at that time, we were told Alzheimer's can't be prevented. There was nothing we could do to prevent Alzheimer's. We were told ridiculous things like we needed to square dance and do crossword puzzles. And lots of us thought, we think there's more to it than that. And so we banded together, created a nonprofit, an online community. You're all welcome to join, whether you're carriers or not. If you're interested in preventing dementia, we're the site for you. So we're ApoE4.info. And we work with researchers from all over the world trying to find strategies to prevent and even reverse Alzheimer's in the early stages. Tonight, we're so honored to have Dr. Georia Ede, a practicing psychiatrist with us. She had one of the best talks of this session, in my opinion, Friday morning. It was so good. And she uses diet and nutrition to address brain issues and brain health. And tonight, Dr. Ede doesn't have a formal talk. We're just going to do a very relaxed Q&A. But I would love to have you start by telling us a little bit of your personal story. Because from what I've read, Dr. Ede has used nutrition to address some of your chronic health issues. And she's doing so much better because of it, and now you're sharing that with your patients. So if you tell us a little bit about your history, that would be wonderful. Sure. And then we're going to do Q&A. Just raise your hand if you have a question. Dr. Ede will call on you. And please try not to monopolize the conversation so everyone gets a chance to ask questions. But thank you so much.
Thank you for the really nice introduction. Do you think we need this?
Yeah. Is it?
Yeah, that
Because I have kind of a soft voice and there's a carpet in here, so it might get a little bit hard to.
And especially when it's recorded.
Is that better? That way I won't develop laryngitis over the course of it. Anyway, so thank you for a really, really nice introduction, and it's really nice to see everybody here and to meet all of you. Some of you in person I've talked with already. So, my personal story. So, let's see, I was born in 1964. No, I ate what I was told to eat for a long time. In fact, well, I always had weight issues. Let me start there. So everyone in my family struggled. We all struggled with our weight, and even when I was a child, struggled with my weight. And so we were always on diets, usually 1,000 calories a day, low fat, exercise. I remember doing that in high school, even in middle school and high school. And it was really hard, and it was successful only briefly on and off. And then I just exercised more and more in college. In college, there was kind of a vegetarian movement on campus, and so I didn't ever become a full vegetarian, but I ate mostly a vegetarian diet because that was what was popular on campus. And then in my 20s, I started to gradually slowly gain weight, and then of course in medical school and residency, it was very hard to keep my weight under control, working 100 hours a week and just not having access to healthy food or cooking for myself. So what worked for me on and off over the years was gradually lowering the quality and type of carbohydrate in my diet. So at first I did the low-calorie diets, the low-fat diets. Then I did low glycemic, and I discovered South Beach diet, and that was actually a little better, a little bit easier. And that sort of stopped working in my 30s, and then I tried Atkins, and that actually did not work for me. I gained weight on the Atkins diet, but my mother lost 90 pounds on Atkins diet. She gained most of it back when she started eating pretzels again. I really loves pretzels. But she's 84 now, working full time, and eats a low carbohydrate diet now. And has kept her weight in a much healthier range, being careful with carbs. So it really just runs strongly in my family. My Nana was Italian and Polish, weighed 400 pounds. So when people like Michael Pollan say, just eat what your grandmother ate, I don't know in my family. So in any case, so I eventually stumbled upon ketogenic diets, and that happened in 2012 when I went to the Ancestral Health Symposium to give my very first presentation. It was actually about questioning the benefits of eating vegetables. And I heard a talk there by Dr. Ron Rosedale. Has anybody here, does anybody know him? So for what he introduced me to was the concept of protein limitation, and that was the key for me. I know that's not true for everybody, and it might not be true under all circumstances, but for me, that was what worked. Not just carbohydrate restriction, but also protein moderation. And so that's how I became introduced to ketogenic diets in all their various forms. So, but along the way, there's another part of the story. So there's the metabolic story and the weight story, but then there's also the food sensitivity story. So I'm 52 now, and about 10 years ago, I started developing a variety of health problems, symptoms that were, very annoying and interfering with my ability to function, things like migraines and fibromyalgia and chronic fatigue and IBS. And I started to look and feel like a lot of my middle-aged patients were telling me they felt, and I was never able to help any of those people. I never knew what to do. And so in any case, at that time I was working at the Harvard University Health Service as a psychiatrist, and so I had access to all kinds of Harvard doctors and specialists, and they were very nice and very smart, very caring, but they didn't know how to help me. They did all kinds of expensive tests, and but they couldn't find anything wrong. But I felt absolutely horrible. So I just decided, since one of the groups of symptoms I was having happened to be stomach pain, I decided, well, maybe it's something about food. At least maybe the stomach part had something to do with food. So I just started to keep a food and symptom journal and gradually tinker with my diet to see if I could figure out what was wrong. I thought, well, maybe it's gluten or something like that. And actually, I'm glad I thought of gluten, because that led me to the local bookstore in Harvard Square, where I saw a book with a piece of toast with butter on the cover, which was Gary Taub's book, Good Calories, Bad Calories. I thought, maybe this is about gluten. And that's actually how it happened. And so I read that book, devoured that book, and read it actually 3 times and took notes. And it completely rewired my brain about food. It all made perfect sense. I couldn't find any holes in the argument. And if you follow that book to its logical conclusion, how many people in here have read that? It's kind of a tough book, but yeah. So if you follow the arguments in that book to their logical conclusion, what you might conclude is that we really only need meat. We don't necessarily need anything else. He didn't really ever, I don't think, come right out and say that, but that's what I took away from that. Or at least that was possible. And I was glad to see that, because when I did my tinkering over those 6 months with my diet, what I ended up with was, instead of my low carbohydrate, high fiber, low cholesterol diet, my high plant diet, I ended up with a mostly animal diet, and I felt fantastic. And I just couldn't even understand why, but that was what worked. And not only did it help all of my physical symptoms, but I had more mental. I was concentrating so well. I was sleeping well. My energy was fantastic, and my mood was better. And I'd never had serious problems with my mood, but I felt much better emotionally. It was a lot less. I guess I must have had some depression and anxiety that I was just used to, accustomed to. And so, I noticed that one of the things I noticed when I changed my diet is this bottle of Advil on my kitchen counter started getting dusty, because I wasn't using it anymore. I used to have headaches and sort of aches and pains all the time. And I thought, well, that's interesting. So all these things happened that I didn't expect to happen. And so, but when I looked at my diet, which was all fatty animal foods and very few plants, I thought, it's going to kill me. So I need to learn. I need to figure out what's going on. And I also, as a psychiatrist, wanted to understand why this diet was so good for my brain, because that was a complete surprise. So I started reading everything I could get my hands on, journal articles. I never looked at a nutrition article in my entire life. I never thought about nutrition except as a weight control science. And in medical school, 2 hours of nutrition training. In residency, 4 years of psychiatry residency training. We never talked about food once. We didn't even talk about food when it came to people with eating disorders. Like, we just didn't talk about it. And so, I left psychiatry residency thinking of the brain as a bag of neurotransmitters, just like that is to be manipulated with medication. Like, that's literally how I was thinking about it. And my training program was very good in that in other ways, meaning that it taught us to think of people as whole people and taught us a lot about psychodynamic psychotherapy and working with people, not just medication-wise. But when it came to the brain, they really only thought about, in terms of manipulating the brain biologically. They did not talk about food. So in any case, that's when I started reading and learning. I have a bit of an obsessive-compulsive personality, and I would start digging into something, and for the answer to a particular question, like, for example, does saturated fat cause heart disease? And I would come up with 10 more questions and go down. I mean, it was really fascinating and a passion of mine, and I loved it. And I loved it so I couldn't stop thinking about it, and I couldn't stop reading about it, and I was driving all of my friends' family crazy. Guess what I discovered today? You'll never guess what broccoli has inside. Thank you very much. Very nice group. In any case, okay. So then I decided, what am I going to do with all this information I'm discovering? I want to share it with people, and I'm burning out my locals. So I thought, well, what do you do in this day and age? You set up a website, right? So this was 2012. So at least that was a place for me to share some of the things that I was learning and connect with other people who were thinking about these things. And so I was just about, so I had written all this stuff for my website. I was just about to go live with it. And I had already started counseling my own patients at Harvard about nutrition if they were interested. At that point, I'd been thinking and reading about it for 3 or 4 years, and I thought, well, it's time to start sharing this in my clinical work to offer people another option. So, because a lot of people, they don't want to take medication, or the medication gives them side effects, or medications don't really work, or they just don't. They want a natural approach. And so I thought, I finally have something else to offer. And the students at Harvard, particularly the graduate students, were really open-minded and receptive, and they got it like that. I would start talking, and maybe 5 or 6 minutes in, they'd be, I got it. I understand. It all makes perfect sense. That doesn't happen in every setting, but it happened there. And so that, sort of helped motivate me to stay with it. And one of the graduate students I was talking to about nutrition said, oh, you ought to go and see if you can talk at the Ancestral Health Symposium, because it's being held at Harvard this year. So that's how I heard about it, and that's how I went, and that's when I first heard Gary Taub speak, and that's when I first heard Dr. Rosedale speak, and all these other amazing people. And it was life-changing. So then I launched my website just a few weeks later, and I've used that. I continue to use that as a way to present information that I've synthesized from about all different things. So not just about mental health, but also about physical health, vegetables, meat. Let's see, what else? Certain conditions like not fibromyalgia. I haven't written about that yet. I'd love to. But hypothyroidism and fatty liver, just whatever strikes my fancy that day, I would write about. And now what I'm trying to do is really focus my website going forward on mental health and nutrition, because at some point you have to focus. And so, but I have found it very helpful and really good that over the past 5 years or so, I've had this kind of brain that's gone in 20 different directions, and it's really helped me to see the big picture. And now I feel like I'm ready, and I feel capable of focusing, because I know enough. I'll never know everything. None of us, we're all learning every day. But now I feel like I have enough of a foundation in all the different fields to feel ready to settle down and really focus on what people need me as a psychiatrist to focus on, because there aren't very many psychiatrists thinking about this, and I want that to change. But I can't think of too many who are doing that. And it's been nice to meet psychiatrists here at this meeting, who said, oh, I feel the same way and I'd love to encourage. It's wonderful. So in any case, that's my personal story. And I came to the Alzheimer's prevention because you might think, how did I get on that? Well, it's because, there is not a lot of scientific research about nutrition and other brain conditions. Other than epilepsy and Alzheimer's, the research is really thin about depression and bipolar disorder. Bipolar disorder, we have 2 case studies in the literature. In schizophrenia, we have maybe 3 published papers, I think. So we just need so much more. So there's just not a lot there to dig into, but when it comes to Alzheimer's, there's this wealth of information, high quality, very mature science, and it's well-developed mechanisms. It's all there, and people have been working so hard on this field. And so I'm just taking advantage of that by reading their research and putting it together for everybody else to translate it for the general public. So, because I think it's so fascinating. And it's a way to understand, because Alzheimer's is a brain disease, a lot of people think of it as a neurological condition as opposed to a psychiatric condition, as if the brain could be divided into psychiatry and neurology, which doesn't make any sense. But what I learned about Alzheimer's taught me a lot about the brain in general and how the brain uses nutrients and what happens as the brain ages. I mean, it's been really important and really in my education about the brain to delve into the Alzheimer's issue, because there's so much there and it's really good quality. So that is a very long answer to your short question. Yeah, okay.
Out of curiosity, do you know your ApoE status?
I do not know my ApoE status. And I would love to know, although I don't think I would eat any differently, because I don't think I can eat any differently because of all my food sensitivities. And I have apologized to our gracious leaders here that I'm not an ApoE4 expert. I know about this much about ApoE4. So if you were hoping for an in-depth exploration of ApoE4, I'm sorry, and dinner's waiting. But I started to, when I was invited to come and speak with you all, which is a real privilege, I really took that seriously, and I was sharing this with Andrea last night on the boat. I took the decision. I really thought, I'm going to get to the bottom of this by the time of the conference. And I started, like, wow, there's a lot here. This is going to take a long time, and it's confusing and it's complicated. But what I can share with you is that this Alzheimer's work, a lot of people have come up to me during this conference really generously sharing their feedback for me about the presentation that I gave and saying, you ought to write a book about Alzheimer's prevention, or you ought to become an Alzheimer's prevention specialist or something like that. I mean, I work in a college, I'm kind of perfectly positioned for that, and I thought, wow, that's a really interesting idea. I hadn't really thought about that. So I do think I might move in the direction of at least maybe organizing a book around this topic as a way to introduce the public to nutrition and mental health, because Alzheimer's is one of those diseases that people can really relate to, and it might be a way in, sort of a hook, if you will, to teach everyone about nutrition and the brain and all aspects of nutrition and the brain. So I am thinking really seriously about that and kind of getting excited about that idea. And if that's going to happen, I'm going to need to become an ApoE4 expert. And as I learn about that, I will share that, whatever I'm learning with all of you along the way, rather than waiting for whatever book may or may not happen. So I would love to do that. And I will also share with you, because anybody in the room can do this, or if you have this obsessive and compulsive streak, how I start approaching any topic. So when you invited me to speak, I thought, well, I need to understand this. Where can I begin? So the way I approach any research project, any research topic, is to think, okay, well, what is my hypothesis about this topic? So usually I start from, and I think everyone should reveal their biases, because we all have them. So my bias is meat is good, meat is a superfood with its fat and all the cholesterol and everything else that's in there and all its wonderful vitamins and nutrients. and plants are trying to kill us. So that's how I look at everything, and I have yet to be convinced that that's not the case. Like, no matter what article I read, I look to see if if that's not true, and I still can't find. And I think there are other people in the room who would agree with me, like the wonderful Amber O'Hearn in the back there, who knows a lot about nutrition. She's brilliant. There are a lot of people who are starting to catch on to this idea, and so when I think about ApoE4, I want to know, okay, well, so ApoE4 is thought of, okay, well, its claim to fame is that it gives you Alzheimer's, right? So its claim to fame, excuse me, something was biting me earlier. Its claim to fame is that it puts you at higher risk for Alzheimer's disease. A little bit higher if you've got one copy, and a lot higher if you've got two copies. So, but the other thing I understand about ApoE4, because I look at everything through an evolutionary lens, and is that ApoE4 is a very ancient gene, and that we used to all be ApoE4, correct? Homozygous, everybody having two copies of ApoE4. So that is a wealth of information right there, because the other thing that ApoE4 is famous for is making it hard for people somehow to process saturated fat. Now, possibly, but that's the question, right? That makes no sense to me, because if this is an ancient gene, why would that gene make it hard for us to deal with an ancient macronutrient? That doesn't make any sense. Now, it's possible that we've damaged our metabolism to a certain extent, that maybe that theory won't really hold for, you know what I mean? Maybe it's true if you're healthy, but maybe it's not true if you're not healthy. So I'm not saying that it's impossible for people who have ApoE4 and have some metabolic issues, that maybe they do have to deal with saturated fat, maybe they do have to limit, but I don't know. And so I would want to look, the next step would be to look at any interventional studies. Like, are there any clinical trials out there? Do a search on PubMed, that's what I would do. Are there any clinical studies out there where they change where they take somebody who's ApoE4, who's double ApoE4, compared to somebody with 2 or 3, and they give them different diets, saturated fat, no saturated fat, and see what happens. I don't know if there are any studies like that.
Yeah, there are, but they're very small data sets. ApoE4 homozygotes, typically there's 2 or 3. And we tend to hyperabsorb dietary fat, especially saturated fat.
Hyperabsorb,
so higher lipids, higher LDLC, higher total cholesterol.
Oh, higher LDLC and total cholesterol, but not necessarily higher triglycerides or lower HDL?
No.
Higher HDL. Higher HDL.
Higher HDL.
LDLP for whatever that means.
Right.
What does high LDLP mean?
Yeah.
LDLP goes up.
Okay, so LDLP goes up,
HDL
LDLC goes up, total cholesterol goes up, triglycerides go down, HDL goes up.
Yeah.
Well, that's fascinating. So if that's what the clinical trials show, it makes me even less worried about ApoE4 and saturated fat. But then there's this other question: is not all saturated fat is created equal? So there's dairy saturated fat, and there's saturated fat from animals like pork and beef and fish and that sort of thing. And there's coconut fat, and there's there's other kinds of saturated fat. Coconut oil is very high in saturated fat. So that's the other question, right? Because dairy is a relatively modern fat. And my opinion about dairy is, different people may handle it differently, but I'm suspicious of dairy as a daily food for a human being. It's a growth formula for a cow, and so why would we want to be eating that every day? But dairy is a really complex subject, and it's not just milk you have to understand, it's then yogurt and cheese and cream and butter, they're all different. And because the processing and the bacterial fermentation, it changes all the proteins and gets rid of the sugar, and now who knows what you've got. So I would just wonder that if there are people who are ApoE4 positive who are having trouble with saturated fat, what if it's the dairy? And is that something that people think about in the ApoE4 community at all or not?
Yeah.
Have
Oh,
to.
sure.
Yeah.
Yes?
We have
Oh, yeah, we've talked a lot about that. We've talked a lot about the A1 versus A2.
Oh, the casing.
Yeah.
Oh, yeah. So, in my very simplistic way of thinking about this, I think that that's kind of a red herring, the casing.
Well, it's not casing, the BNC7, the protein, a damaging protein that comes as a result of the A1.
Yeah.
Right. And
But-
it's not found in the A2.
Yes, but those are forms of casing, correct?
Yes.
I think so.
Yes.
Yeah.
Yes.
Yes? Okay. So those different forms, the A1, A2, those are different forms of casing. So milk has fat, it has lactose, which is the sugar, and it's got protein, primarily two proteins, about 80% casein and about 20% whey protein. So casein is the big, sticky, globular protein that's designed to clot in the stomach. And I have some theories about why that might be. But in any case, baby cows have an enzyme in one of their stomachs called rennet, or I think chymotrypsin or chymosin is the other name for it. Anyway, rennet. And that enzyme is the one that's designed to break down casein. We don't have that enzyme in our system, of course, because we're not cows. So we're not supposed to be, I think, drinking this stuff. So there's a lot of science. I've looked at this in a variety of different ways. There's a lot of science on infants and young children having a lot of difficulty with cow's milk, and it takes them much longer to digest it, and it can be quite irritating and cause a lot of side effects as a result. So that's clue number one, that milk may not be a good idea for us. But the A1, A2, I mean, so they're higher quality casings or older casings and so forth. I think that's, I don't know how much that would impact the saturated fat issue. So the saturated fat is a different portion of the milk. And then there's the whey protein, right? So the whey protein is what sits on the top, the watery stuff that sits on the top, and then the curds sink to the bottom when they're making cheese. So that watery whey stuff, that's actually very easy to digest. We digest that well, cows digest that well, and the whey protein, even though it doesn't have any sugar in it, can trigger our insulin levels and growth factor levels to rise because it's a growth formula. So it's trying to turn a little baby cow into a bigger baby cow. So it turns on the cow's growth system, and it can also do that in us. So the different components of milk are all really interesting and complicated. The saturated fat part is also where a lot of the hormones are, the natural hormones that are supposed to be in milk, that the mother cow is imparting to the baby cow. The hormones are signals, and it's sending signals to the baby cow system. So the saturated fat is not just fat, it's got active molecules in it that are affecting us in different ways. And I think some people do well with dairy and other people don't. I unfortunately don't do well with it. And the truth is, if I did do well with it, I'd probably be eating some because it's really good. But in terms of if people who are ApoE4 positive are seeing their numbers not where they want them to be in your lipid panels, or if you're any other issues that you're not sure, if you haven't removed dairy as an experiment and then gotten yourself retested, that's might be worth doing just as an experiment to see if it makes any difference. So those are the kinds of questions I had in my head when I was starting to look into this, and then got too busy to finish looking into it. But I would like to learn more about it, and if I do learn more, and I've looked at your website and read a lot of Andrew's excellent articles, a lot of her writing there. So I feel inspired to learn more. And if I do learn anything that I think would be helpful, I'm happy to share it. But that's that much. I know that much. So, yes?
I just finished reading Dr. Kelly Turner's book, and I was wondering if you've read it.
Kelly, who's that?
Am I saying it right? Oh, Dr. Kelly Brogan.
Oh, Kelly Brogan. Yes. I have
Mine
not.
is your own.
Yes, I have not read that book. But please tell me what you thought of it.
Oh, it blew my mind.
Yeah?
It was like listening to Dr. Nasha speak about cancer this morning. It was almost like someone unraveling like the root causes of bipolarism and schizophrenia and depression and anxiety and bulimia and anorexia.
Wow.
And I mean, she was basically, she's using food as medicine, just like what you were saying, so.
What does she recommend?
You know, she is kind of recommending, my sister was inspired by her video. She has an amazing video on YouTube where this woman was in college, had a low-grade eating disorder, went into her college person, you know, for a health clinic, put her on antidepressants, she got worse, they put her on more antidepressants. All of a sudden she was like getting worse and worse and more symptoms, to the point where by the time she made this video, she had been in and out of psychiatric hospitals for 25 years.
Wow.
And then she had a naturopathic psychologist send her to Dr. Kelly Brogan in New York, and she also has an online program that my sister's on. And within a couple months, she had weaned tapered very successfully and slowly off of the medications and onto a whole foods diet, which I would describe as paleo-esque.
Okay.
I don't know how much the ratios are. It seems like she emphasizes a lot of fats, but definitely not like a ketogenic type thing. But she's emphasizing a lot of great things as far as micronutrient deficiencies, the B vitamins, and all the brain food that you were just talking about. So
Right.
I was really thinking that you two need to get together.
You are not the first person who's recommended that. So I would love to meet her, and I'd love to.
Me too.
I would. When I first heard about her, which wasn't that long ago, I think maybe a couple of months ago, I took a quick look around her website and read a couple of articles. But I don't know enough about her. But I would love. I think she's in New York, right?
She is.
So,
and
She was
yeah.
at NYU. I had several friends in residency who got to actually practice under her. She's very nice, very approachable. She takes a functional medicine approach, more of an autoimmune paleo.
Okay, great.
Yeah,
so-
very autoimmune as well, you know, no dairy, no nightshades, and then she's really good though because she gets into certain things like get rid of your Teflon pans and,
Yeah.
you know, don't drink out of plastic. She has
Toxin solution.
Yeah.
Yeah.
And I think that what's interesting is my sister has tried a million different programs for depression, and she unbelievably watched this video with me one day, and she signed up for the program. And it's, I guess, every day they give you another step
Oh,
on
wow.
her program.
Uh-huh.
And so my sister's on like day 45. I almost fell off my chair. She's overweight. She's never done anything like to take care of herself ever. And for some reason, this woman is motivated to her. So
That is fantastic. That's
Yeah.
exactly what you want to hear. You
yeah,
know,
my
there need to be
sister's
more
my sister's in
psychiatrists.
your area, so I'm going to send her to come to
Is she enrolled at Smith College? Because those are
She
the
went to graduate school there.
Oh, she
and
did?
She is a social worker, and she
Oh.
prescribes antidepressants. And her first tirade when she saw the video was like, "No way! All my clients need antidepressants." And by the time we had watched like 20 videos, she was like, "Maybe I need to rethink this."
That's really interesting.
So-
Thank you very much for.
She wants to start a clinic in your area, which will be the first clinic for underprivileged people that would focus on diet over.
I love that. Because
Antidepressants.
this information needs to get to everybody, and
It does.
and people lower on the socioeconomic chain. I mean, they have
They don't have access to
really
this.
poor access to information and services, and often their appointments are too short or they're too far apart, and it's really hard. Oftentimes when I'm giving talks in community settings, one of the, like at local public libraries and things like that, one of the biggest questions people ask me is, they say, I can't afford to eat this way. But it's actually not true,
Yeah.
because as everybody in this room probably knows, some of the healthiest cuts of meat, some of the most nutritious ones are the least expensive. And so, the fatty ones, the ones with the skin, all those kinds of things, you don't need the extra lean this or that, or the white meat chicken breast, that kind of stuff. So all of those, I don't think it should be a barrier. It's just the information needs to get out to everyone.
She has a fun video where there's a woman who does it on food stamps.
Wow,
Yeah.
that's great. Well, as a child of a family that grew up on food stamps, I think that's a beautiful story,
I
actually.
do too. Thank you for your work. Thank you.
Thank you, and thank you for letting me know about other people's good work. Yes?
Where do people follow you, your blog or website?
So where do people follow me? So I have a website called diagnosisdiet.com, and I will warn you that during the academic year I publish fewer articles than during the summer, which I have off, but I do my best to keep up with that. I also I write 3 times a quarter for Psychology Today. So I started doing that a year ago, so I've got 12 or 13 articles up on Psychology Today, including the one about preventing Alzheimer's disease. That's all free, of course. And then I'm active on Twitter and on Facebook, and those are actually the easiest ways to ask me questions, because in the beginning, when I first started my website, I would try to answer every question that people wrote in the comment section of every article, and in the beginning that was actually pretty easy. Now it's impossible. So I do answer the questions on the new articles, but it's just too time consuming to do that. But if you write to me directly on Facebook or Twitter, I will almost always answer you. So, because I'm keeping track of that. I don't know why it's easier that way, but. So, yes?
So there's a little known secret, right, in our fields. I'm a neurologist and you're a
Yes.
psychiatrist. We take the same boards.
Yes,
And,
the Board of Psychiatry and Neurology.
The APN, the American Board of Psychiatry and Neurology. And so don't feel at all uncomfortable, like delving into Alzheimer's dementia. And in fact, last year at the American Epilepsy Society conference, there was this amazing talk on the epilepsy of the future. So all of the speakers had to get up and postulate what epilepsy would be like in 20 years. And the phrase paradigm shift was thrown around multiple times. I mean, keep in mind, in epilepsy, 35 to 40% of patients are not responding to medication. And the ketogenic diet is actually where epilepsy kind of blossomed, right?
Yes, yes.
But, what they said in epilepsy was stop thinking of the psychiatric comorbidities of epilepsy as comorbidities, right? That was a huge paradigm shift, because we're always like, oh, well, they've also got depression and epilepsy. I call it deprelepsy, right? Depression
I love
and
that,
epilepsy.
deprelepsy.
Right? And so there's a number of neurologic diseases. Like, each neurologic disease has a psychiatric comorbidity. Like with MS, right? You have a certain, with Parkinson's, the pseudobulbar palsy, ALS, right? You think about every single neurologic disease, and every single one of them has a psychiatric comorbidity, and it's very interesting because each of them manifests differently. So please, delve into Alzheimer's and do it fearlessly and shamelessly. You're not like stepping on any toes.
I won't be, I won't be creating turf war situation. It's just so funny, it's bad enough that we divide the brain into 2 halves, but we divide the brain from the rest of the body too. So it's just all the same organism.
It really is.
Well, thank you for your stamp of approval, and if anybody sues me, I will send them right to you.
Have you observed any sort of connection in terms of psychiatric disabilities, issues, that sort of thing, migrating into cognitive Alzheimer's, dementia type things? Is there a continuum there that you've observed?
That's a really excellent question. So I used to work with adults of all ages for the first, during residency, of course, those 4 years, but then for the 5 years after residency, I worked on Cape Cod in Massachusetts. There were a lot of older people, a lot of seniors, and a lot of retirees on Cape Cod, and so a large portion of my practice was older people, sometimes some in their 70s, 80s, 90s, and then younger people, so everyone from 18 to 90, and so when I was doing that work, I was noticing all kinds of interesting things, and now that I've, in terms of, let me give you a few specific examples. So in terms of the overlap between cognition and emotional health, people with bipolar disorder seem to have some cognitive deficits, subtle cognitive deficits, which can be picked up on neuropsychological testing, but which otherwise are kind of hard to detect. And a lot of people with bipolar disorder will say to me that they have a hard time concentrating and remembering, and they come across as perfectly well. But these are the kinds of things you don't need to be able to pick up on a test. A lot of people with bipolar disorder also meet criteria for ADHD, and meaning that they have enough symptoms, inattentive symptoms, to have what a comorbidity, right? So bipolar disorder and ADHD, that overlap there's a lot of overlap there. And so, but now thinking about larger mechanisms in the brain as a whole, insulin resistance is not just the underpinning of Alzheimer's disease. We also are starting to understand that it's contributing to at least the severity of symptoms of depression, bipolar disorder, and psychotic symptoms. And the way we know that is first just a correlation, which may just be a coincidence, but people with bipolar disorder, depression, they all have much higher rates of diabetes, much higher risk of diabetes than other people. And schizophrenia for 3 times the average population. So, but that just might be a coincidence. With depression, it's 2 times the general population risk. So it suggests there might be something going on there, but we don't really know. But then there have been some studies that have come out. The researchers are so funny. They say, oh, insulin resistance might be contributing to depression or bipolar disorder. Let's give them a drug. So they gave them a drug that improves insulin sensitivity. It's a drug called Actos or pioglitazone. And would you like to say something about that?
Not a good drug.
Not a good drug. So it's not anything I've ever prescribed. I'm a psychiatrist, and so I don't prescribe those medications. But they've done studies with that drug in depression, treatment-resistant depression, meaning other medications hadn't worked, bipolar disorder, and schizophrenia. And in every case, on all of those research studies, that medication reduced the symptoms. So that's fascinating, right? So that means that insulin resistance is playing a role in people's emotional symptoms. So, and we don't understand exactly why. The research is very new. But what if it's the same? What if it's all the same thing? What if it's all just insulin resistance and not enough insulin getting into the brain and glucose not being able to be metabolized and all the cells are struggling and maybe the whole brain is being affected as opposed to just little pieces of it? And it's causing seizures and it's causing depression and it's causing Alzheimer's disease. And I mean, one of the wonderful things about this conference that I went to, this International Society for Nutrition and Psychiatry Research, which is a brand new organization. I'm so excited about it. So that organization was founded by, and the president of that organization is Dr. Felice Jacka. She's a psychologist, a researcher who does epidemiological studies, which are just observational questionnaire-based studies about dietary patterns and mental health. But then she also just did the very first randomized controlled trial of diet and depression. She chose the Mediterranean diet, so and it did help a little bit, but that's a great start. And so she founded this organization, and one of the things I got out of this organization was there were 3 researchers there that really I just completely changed the way I think about psychiatry and nutrition, actually, even though I think about it a lot. They've all been doing this work for decades. The senior clinician there, the senior researcher there, Professor Michael Crawford of England, I don't know if anybody's ever heard of him. He's been studying nutrition, and particularly the quality of fats, dietary fats, and brain health for decades. He's 87 years old. He's sharp as a tack. He's a lovely, distinguished, brilliant man. And he said, there is no health without mental health. And he warned the WHO, the World Health Organization, in the 70s of the coming global mental health crisis. He said mental health is going to be next because we're not feeding our brains properly. And that just kind of sent chills up my spine. And he said, we are literally losing our minds. We are, we're becoming more violent, we're becoming more disorganized, we're becoming more disabled. And, I, as a college psychiatrist for the past, when did I start doing college psychiatry? 2007, so I guess 10 years. 6 or 7 at Harvard, now Fort Smith. As a college psychiatrist, I'm well aware, and all of my colleagues are, that every year we are seeing students enter their freshman year less and less capable. From a brain point of view, they're coming in on all kinds of medications, needing all kinds of special services, needing accommodations, needing support, falling apart at the drop of a hat. The littlest stress comes along and they are They have no resilience, and it's not just about parenting trends in this country. It's about something much deeper than that. I'm convinced. And they're overwhelming all of our services across the country. It's a nationwide crisis in college mental health. We are all overwhelmed. We're all on waiting lists. We can't hire enough people. It's really scary. These are 18-year-old people that should be in the prime of their lives, functioning at the top of their game, and they can't concentrate, they can't sleep, they can't remember what they've studied, they want to kill themselves. It's horrible. Working in a college mental health service is like working in an emergency room. It is really very, very high-level psychiatric work. It's not what you might expect. It's fascinating and terrifying, and we have to do something about it. So, and none of these kids want to change their diet. None of them do.
I'm
Yes.
just curious, as you've worked with some of your clients and all that, and you've got them on nutrition-based plans and all that, have you seen a decrease in the drive to use like the internet and stuff like that? Because now they're more willing to, I guess, talk to people, be more social and all that, where I gotta imagine a lot of your clients going through the college right now are so ingrained of having their face in their phones and all that, so they lose some of that social ability. And I was wondering if that drive to always be on the internet and be alone and blah, 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 is driven due to the poor health of not eating properly. Have you seen any correlation there?
That's a really good question, like what role technology plays in student social isolation, and whether diet, a better diet will sort of get their heads up out of their phones and actually interacting with people. I can't answer that specifically. I think it's a really good question, and one I will think about more as I go back to this academic year. But I will say that